Dr. Cleveland's career is devoted to understanding the differences in the impact of environments on people's experiences and behaviors. An underlying assumption of his work is that experiences, such as those within families and friendships, act together with individuals' characteristics to shape developmental outcomes, such as substance use and abuse, as well as the impact of these behaviors on people's lives. Dr. Cleveland focuses on gene-environment interactions, impacting the initiation and escalation of substance use among adolescents, and understanding within-person processes that underlie relapse and recovery from substance use disorders.
So just a little bit of background. I really can't say I have been working in the recovery area for 15 years, but about 15 years ago, I had the opportunity to dip into the recovery research area, and I have maintained some level of involvement since then. It's actually given me opportunities to branch into different areas involving ecological momentary assessment. Since I am now, I received the last real raise of my life a few years ago, so now I have the freedom to do more things that I want to do. And I'm sort of committing myself full on to doing work in the recovery area. So now it is officially my jam, and so it's what I'm going to be working on. And a lot of the stuff that I'm going to be presenting is stuff I started on years and years ago, and then have, when I'm been in sort of getting back into it the last few years, I find that a lot of the things I wanted to do, I still want to do, and I'm getting all those things sort of ramped up at this point. So this talk is called "What is Recovery and What is Needed to Support It?" This is a brief outline. Basically, I want to talk about the problem. I want to talk about what recovery needs, and then my sort of innovation in this talk is getting into the area of what really is recovery, how is it defined, how can we start to operationalize it in a way that really does it justice, and also gives us a way to study it in a fashion that will produce information that we can act on to improve people's recovery. And I want to talk about recovery capital, which is really very connected to recovery. It's very difficult to think about recovery without actually referencing recovery capital, which is something that I really started to work on unknowingly about 15 years ago. And then about 10 years ago, it came out as a serious operationalized construct in the recovery literature while I was back doing my behavioral genetics. And then I want to do a review of sources of recovery support. And when I get done, we can talk about what parts you want to emphasize, and we can have a discussion about those parts. So first of all, recovery is what happens hopefully after treatment, and how people maintain sobriety. The big issue really is that a lot of people are focused on treatment itself, and a lot of money goes to treatment itself, but 60% of patients who are entering treatment have been there before. 50% are entering for a third time or more, and 10% are going in for their sixth time or more. And so this is not something that you go to treatment for and boom, you're okay. This is not just a US issue. They have the same issue in Australia and England. So in addition, there's interesting work by John Kelly. And I'm going to try not to copy too much of John Kelly's work in this talk. It's hard because he's so influential. But he basically he reports that only 28% of people who consider themselves to be in recovery actually went to formal treatment. So the relationship between treatment and recovery is really imprecise. So, and this is blatantly stolen from a John Kelly presentation. I want to be recorded saying that. This is a great analogy for what recovery needs. And really, it's about your life being a house, and what we're good at when the house is on fire. So we're really good at showing up with the fire department and putting out the fire, detoxing people, stabilizing people, helping people become, non-active users for a moment. But then what happens is the fire department goes away and you're sitting there going, oh, I have a big problem. So we don't really do anything to prevent it from reigniting. We're sort of reasonable, a little bit of that. Treatment, when you go to treatment, you get a relapse avoidance plan. And then you should get a recovery plan after that. We're not great at that because not everyone can actually, develop a solid recovery plan. What we're really horrible at is providing people with the rebuilding materials needed to actually maintain recovery and live a life afterwards. These houses have to be rebuilt. So a key point for that is that recovery capital is important for the rebuilding process. Recovery capital is something I'm going to talk about a lot today. It's the social, physical, human, and cultural resources necessary to begin and maintain recovery from substance use disorder. And I first started thinking about recovery capital really sort of unknowingly because it's more of a, this is sort of a sociological analogy in terms of human capital and social capital. But I used to work with the collegiate recovery community, and when I was working with that collegiate recovery community, I was always reflecting upon my own family's history of addiction and thinking, wow, the people who are in this collegiate recovery community have so many more resources than I knew my father had, and also I knew that most people had. So what I was really talking about at that point, thinking about, was recovery capital, and how people who are in collegiate recovery communities tend to actually have a lot of it, and other people don't always have a lot of it. Hold on. So next, sorry, there we go. That's it. So what is recovery? And this slide is packed full of 4 different definitions of recovery with little red bits to point out what I think is really important. So the first one is from the Center of Substance Abuse Treatment. Actually, before I do this, I want to look at the dates of all of these definitions: 2005, 2008, 2014, and 2018. We're 15 years away from the first definitions in this area, and that's shocking because recovery has existed for a long time. And this is really what happened when policymakers decided they really had to focus on recovery. We needed to have some definitions. So these definitions, such as the first one from the Center of Substance Abuse Treatment, that say that recovery from alcohol and drug problems is a process of change. Hold on, your faces are covering the rest of this, so I got to move that. Through which an individual achieves abstinence and improved health, wellness, and quality of life. So we have a process of change in there. It's broader than abstinence as well. Second one is a process of recovery. Second one emphasizes the process of recovery. So we have the word process again. From problematic substance use is characterized by voluntarily sustained control. So we have people who are doing this actively. They don't receive recovery. And once you have it, you have to work to maintain it. And it maximizes health and well-being. And so it's not just abstinence itself. The third one is from John Kelly, which is recovery is a dynamic process. And so we've added the word dynamic in there. And then he focuses on it being a stable remission. John uses the word remission instead of recovery because he's emphasizing the link between this and other diseases. And he wants this treated as any other medical condition. So it's resulting in and supported by increased recovery capital and quality of life. So this definition actually includes recovery capital. And the last one is a definition I was involved in constructing a few years ago. And it's an intentional, dynamic, and relational process. So this is really situating people, an active person in a dynamic process where they're connected to other people, and involves sustained efforts to improve multiple aspects of wellness, which may vary by individual, social, and experiential contexts. And the last bit is to really emphasize that 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 there's a lot of variability in how people can maintain recovery. So how do we understand and study recovery? First of all, I want to recognize what it is not. It's not abstinence, either at one time or measured across multiple assessments. It's not a single time point assessment of well-being. When I was working in this area in the early 2000s, people who were in recovery research kept focusing on their new measures of recovery. And what they did was they added aspects of depression to abstinence measures, and they were like, boom, slam dunk, we're done. And so I do not think it's simply just adding well-being to abstinence and saying that you're done. So what I believe it is, and what has to be measured and analyzed in order for this to be a useful endeavor, is that it's dynamic. So person-level traits and varying states transact over time. It's intentional. You have to have an aspect of the human acting on their environment. It's relational. So this is situated with the person connecting to other people. It's heterogeneous. So this is speculation because people don't do this research, this last bit, is that it's very likely very different for different people and across different contexts. This pops up in some ways. Everyone sort of, believes, oh yeah, it can be different for different people, but they don't always operationalize it that way. And also, there's an acknowledgement that recovery is really different depending upon who you are and what circumstances you're in. And that pops up. For example, I was talking to people in the Philadelphia area who run recovery houses, and we're talking about a study that we're going to do in Lancaster. And they looked at me like, well, that's nice for Lancaster and the people in houses in Lancaster. But if you're going to work in Philadelphia with people who've been on the street as heroin users for 15 years, you're going to have to change what you do because their recovery is different. And that's not as good. It's just harder, and the challenges they're going to confront are going to be different. All right, so I'm going to break this down a little bit. So in terms of cross-time dynamic process, recovery is not a moment. It must be assessed across time in a span that captures the variability in the external experiences and the internal states. So if someone is experiencing triggers in terms of their social experiences, when you study it, you have to capture enough of those triggers so that you can understand how those triggers are connecting to their internal states. So for example, in the area, so for internal states, everyone has good mood and bad mood every day, but you may not have a social conflict every day. But if social conflicts are a big part of how you deal with them, a big part of someone's recovery, you have to measure, you have to capture enough and have a broad enough measurement net to capture enough variability in those external experiences. You have to both capture the means and variability for all the external experiences and internal states. And you have to capture the reactions between these experiences and these internal states. So this is an example of craving. Craving is sort of very central in the addiction literature. It theoretically goes back a long way, but there's some questions about how useful it is as a concept, and I believe it's actually due to measurement issues. So this is measures of craving that we got from people who are in opioid use dependency treatment in a residential care facility in Pennsylvania. There's 70 individuals. This is their average amount of craving from top to bottom. You can see here that there's some variability. Some people crave a lot, some people crave a lot less on average. And then you have the X over here, which is showing the average. Now, this, if all the information you have is this, you're sort of assuming that that everyone's craving is stable across time. So I've drawn all these lines across there, and those are not produced by data, those are produced by Bo. Just little lines all the way across to show what the assumption is. So if you actually have cravings at this time, you're going to use them to characterize a person's cravings, this is what you believe is happening. And now you may say, well, I don't really believe it's really stable, but I believe that there's some, wiggleness around this, and there's some variability. And so, the craving may not be exact and it may change, but really, it's still a pretty good approximation, adjusting for all of this error and time to time variability. So I've drawn a bunch of spaghetti lines there to show you what that assumption would look like. But actually, when you look at the data, what you see is something really different, which is that the variability across time, and these are day 1 to day 12, and in the residential treatment facility. And what you can see here is that there is an average decline across time. So one thing is that this goes down across time. So even that mean is not accurate. Moreover, it's not accurate because there's so much variability across all these individuals. You have a low-lying group, you got some people who are going down, you got people who are going up, you got people all the way up here. So so the mean is certainly not accurate, and also it's not stable. And I'm trying to move ahead, and it's, oops, sorry, got a little bit of a delay. So in the spirit of Christmas, I've gone to the candy cane approach and shown that there are people, these two individuals, craving levels have means. They're the same means. And if cravings are bad, and I'm not going to actually say that they're bad because we really don't know. I mean, in some ways, cravings are bad, but if you don't get used to dealing with them, that's probably also bad. So, so there's really not a very clear relationship between cravings and outcomes. But if cravings are bad by themselves, I'd rather be the red candy cane person than the blue candy cane person. And they have the same mean. So just relying upon a mean is really at a threshold level a mistake. Now, we measure these things 4 times a day. And what this shows is the variability in assessments. This is the average variability in assessments. So when we look at everyone's data in the morning, before lunch, in the early afternoon, and evening, this is what their pattern of cravings look like. One thing I want to point out is that this is the exact opposite of what the clinicians hypothesized that we work with. The research clinicians and the on-the-ground clinicians, they both generally agreed, well, that in the morning, because you've been out without your drug for a long time, you're going to wake up with more craving. And the evening, this is when you generally use, so you're going to have more craving then. And it's just the opposite. Luckily, I'm not really hung up on hypotheses, so I just said, let's just run it. So I was not wrong, at least. So that's the way it looks. This is a pattern across time. And there's significant differences between the morning and the late and both of the afternoon cravings. Now, over time, all these parameters shift. All these values shift. This is what they look like early on. So in the beginning of treatment, there are massive differences. And then as treatment goes on across time, what you see is that the differences really decline to the point that actually when you're outside of that little box, that's a significance box, there's no longer any significant differences between those different craving points. And then you can see this is the shape that we had in the beginning, and across time, every 2 days, this is what happens to that shape. So you have a lot of variability in the shape and its transformation across time. So in terms of being intentional and volitional, I'm relying upon my favorite cartoon character, Calvin. And so this shows how Calvin is affected by his relationship with Susie. And then what he can do when he reaches out to his sponsor, or his other support people, and then how he can maintain well-being. So first, in terms of this pattern, and this pattern, I mean, it's more than just his well-being. This is the pattern across time that maybe defines Calvin's well-being. and how, because his well-being is not just his level of well-being, but what triggers he has to manage, and then how he manages those triggers. So it's important. I mean, from a therapeutic perspective, most people are encouraged to try to minimize triggers, but you can't always avoid triggers, and so they're going to exist. So you have to try to reduce the impact of triggers, and you have to develop social networks and social support. That these systems of support have to be built, they have to be maintained. Importantly, they have to be used when someone is in need. And hopefully this process works out, and then Calvin maintains his well-being. So in terms of social support, I just have Calvin's buddy Hobbs here. But in recovery, one of the primary predictors of well-being is actually someone's social network. And this is a measurement device that we used, which was a modification of the important people's activities inventory, which we changed for people in long-term recovery to try to measure people's social networks in a more sensitive fashion in a collegiate recovery community. And this is the first work that I'd done in this area. And so what we did was we basically gave people these grids to fill out. And this is normally filled out in a clinical setting, but we were able to have people fill these things out, like 50 people, at a setting. This was all done in one time, and basically filling out these different grids, and they describe their social networks, and then describe, so who's in your social network, and then also who, are they drinkers or not? And then we have another page which actually classifies them according to whether these are the most important people that carry information over. So it's a little bit complicated, and I wouldn't advise using it in all populations, but these are pretty functional, pretty stable group of kids who average about 1.5 to 2 years of sobriety in recovery. And this shows what a protective social network looks like in a collegiate recovery community. And this is a large collegiate recovery community, probably one of the largest actually. At the time it was about 75 people, and now it's over 100 people at Texas Tech. And if you look at the top, you can see that the total abstainers, this is the number of abstainers that they have on average, and then you have also the how many of them are carried over, and these people rank as their most important abstainers. And then if you compare that to the number of people who are drinkers and the recovery risk of the social network, this group has about double the supportiveness as they do risk in their social network. And so this is a very important part of their program, and of their, well, it's really not the program, I should distinguish that, of the social context. Incredibly supportive is being surrounded by this incredibly supportive social network of a very large collegiate recovery community. Now, this is the trippy part. This is how to understand recovery and process variability. And a lot of process, but also population variability. So in terms of the behavioral science in general, we make a lot of nomothetic assumptions. Rather, than all people, but rather than all people having similar types of recovery likely differ substantially. And this is related to the idea that there's a lot of population heterogeneity. So this is a wide audience I'm talking to here. There's researchers, there's non-researchers. So this is going to get a little bit techy. Just let me know later if you want this explained differently. But so basically, in any sample, it's really easy to assume everyone is essentially similar, and that they differ just in a matter of degree from some general average. But a lot of people know that that's not true, and so they use these different statistical approaches to identify the mixture that's actually happening or the latent classes that are actually inside the sample. And this is true for delinquents, for adolescents who are drinking. There's problem drinkers, there's light drinkers. So these techniques have been used to identify lots of different subpopulations and different types of samples. And in recovery, there's probably a lot of differences. Just we don't have the data yet to really distinguish between the different strategies that people are using and the different lives people are living inside recovery. So secondly, and this is the sort of extreme statement, is that the structure of inter-individual variation is rarely applicable to analogous structure of intra-individual variation. I should probably turn on my little set of faces so I can see people go, what? What this means is that if you collect data from a sample of people and you only have one time of analysis or multiple times multiple data points, you almost always use between person analyses. And when people have examined whether you can apply within person findings to between person processes, they almost never apply. So this means that the vast majority of our psychological science does not apply to the processes that a great majority of our psychological theories actually link into, in terms of, when we talk about psychological stressors, we tend to say, well, when this happens, that happens. And so we're talking about time unfolding, but most of the data points really don't show that. Most of the way that we go about studying these things really doesn't show that. So, so I think psychology research is on the cusp of a revolution in terms of, really embracing within person analyses. And so as a result of this, person level data on interpersonal stressors, mood, social support, et cetera, is of limited value when applied to actual individuals, because these things don't apply to individuals, they apply to groups, because they're developed from they're fit to groups. Thus, developing a successful, in other words, data one could use to intervene with an individual, understanding of recovery requires using within-person data to understand within-person processes. Trying to advance, not advancing, hold on. Oh yeah, sorry. Okay, it was advancing, sorry. So to demonstrate this, I'm going to use data from a project that I did with the grad student. And we collected data from people, this is actually from people in a collegiate recovery community. And we collected 30 days of data, actually no, 24 days of data, it's right here, from each individual, and daily reports on their smoking behavior, their craving, and also their negative affect. And we fit everyone to their own basically structural equation model program. And then everyone got their own pathway model. And then we added in, then we decided which of these pathway models fit together using cluster analysis, based upon the parameter similarity of each individual's model. And so out of the 30 people, we got about 6 people in this one group. And you can see that negative affect, basically on one day predicts negative affect on the other day. So these are autoregressive models where one day predicts the next day. And then cravings predicts cravings one day to the next. Now, tobacco doesn't predict tobacco one day to the next, but this group really has a lot of things, negative affect, tobacco, predicting cravings. And then, I'm sorry, this is going to advance really quickly suddenly. I'm going to be on like 4 different slides. Sorry, everyone. Oh, there it is. Who knows how many slides that's going to advance? Anyway, so this is subgroup 2, and you can see that they're really different. Their negative affect across the association is about half. There's no association between negative affect and craving craving itself doesn't actually cascade across days. And then in addition, tobacco actually predicts craving the next day, and there's a strong tobacco to tobacco cascade across days. Now, what we did to show this is valuable is that we grouped it, we grouped things together and ran it as if everyone's really the same. And what you get is a model that fits no one. And so this demonstrates that if you're fitting the models to everyone, it's basically like buying, a jacket for like 6 different people. It fits no one well, and it's really not very, very useful. So this is a, long nomothetic problem we have in behavioral science. And also this shows that this can be done with data that we can collect. All right, so back to Calvin and his relationship with Susie. Interventions need to be timed to support when things are happening. If you want to intervene, you need to support, actually intervene, when Calvin's having a problem. So they have to deal with not only when, but also different external risks. Some people, they're really going to be bothered by their relationship. Other people are going to be bothered by their work situation. Other people are going to be bothered by feeling overly positive and they want to go party. Similarly, different internal states are going to be different and important for some people. Some people positive, some people negative. Some people cravings will be a big deal. Other people, not at all. So just the fact that cravings in general doesn't actually predict for samples reliably doesn't mean it's not crazy important for a third of the people. And if you hit reverse in this thing, it really doesn't like you. Okay. No, I'm just going to pause and then, okay. And then, nope. You're recording me.
Sometimes I have this problem, and it's usually because the computer has switched over to Zoom, and so when I go to advance the slides aren't responding.
I'm going to go down and use Zoom to say next. Oh, that worked. Okay, that didn't work last time, so we have a lot of variability. Similarly, different resources are needed for different people. Not all resources are going to be the same. This is not a one-size-fits-all situation. And finally, what wellness is and what recovery is going to be different for different people. This last part of the talk, I want to just review different types of recovery support. We generally think about treatment and mutual help support groups in terms of addiction and recovery. And a lot of people go from treatment to mutual help support groups. A lot of people, don't actually take that path and they're just coming in from the outside. But there's been a lot of growth in the last 15, 20 years in terms of recovery support programs. This growth recognizes that people really need to have support after the fact. And just simply releasing people from treatment into mutual help support groups and hoping that things work out well is probably why we have about 80% of the people coming back and coming back quickly too. So we're just not very good at recovery as a society. We're really good at treatment, cleaning people up, giving them the basic tools. And then we send them into 12-step groups. But that's really just meeting a day that doesn't actually, address lots of issues they have across their entire lives. So this um, this slide basically says that the main thing recovery support services are supposed to be doing is providing recovery capital, which is basically the tools people need to attain recovery and maintain recovery. This slide's got a lot of stuff on it. I want to go through it slowly. Let me just see here. So recovery capital in general, it's the total resources that people have to build and maintain their recovery. It's broken down in these elegant ways. This borrows heavily from sociology and actually going back further and sort of, using the analogy to capital and human capital and Marxist capital. And so it comes to us through sociology. And it's, one of the main areas of recovery capital is personal recovery capital. This is basically physical and human capital. Physical is just the resources people have. In some cases, these are very basic resources. Their health, their healthcare, financial resources, clothing, food, safe shelter, basically transport. I mean, all these things that, if my children or myself, if I end up needing recovery support because I'm fortunate, I probably will have a fairly high amount of these things. But a lot of people have very, very little. And in addition, this is linked to human capital. Human capital relates to people's abilities, skills, knowledge, problem solving, education, their credentials, their self-esteem, the ability just to navigate society, challenges, interpersonal skills, and also the degree to which they live a purposeful life. So if they have a job, they may feel more purposeful. At the beginning of the COVID spring, I was talking to people who were running recovery houses, and they were saying that, and just a small sample of someone who's involved in managing several recovery houses in the Harrisburg area. And she said that they lost 2 people because they immediately lost their jobs, and they had management positions. This is the only thing that they had going for them, a large sense of their identity, and they overdosed and passed away. And it's because they lost their sense of meaning because the sense of meaning was tied into their job. Social recovery capital is basically the social support that we have, not only how many friends we have, but also who these people are, what sort of resources that they have. And then there's also community recovery capital. This is a community level version of recovery capital. So it's not just, the recovery capital I have, it's like what resources are there in the community. So if a college adds a collegiate recovery center, a program, that community has more community recovery capital. Just very briefly, in terms of cost, in terms of society, treatment's crazy expensive. Recovery support is much less expensive. So even the more expensive versions of these programs, they're much less expensive than treatment, especially when people are going back to treatment again and again. In terms of recovery support, there are these different sources of recovery support: educational, mutual health support groups, educational programs, clinical recovery management, recovery housing, recovery community centers, peer-based support. And all these things are basically similar in some way to mutual health support groups. And this is a breakdown from John Kelly's work, which shows really what the main source of, or the main mechanism of support is actually through the social network support for abstinence and other aspects such as recovery motivation, recovery abstinence. And then there's the more psychological aspects. But a lot of this is really just social support and community. I want to just very briefly go through these things and just probably just hit the titles because I'm running out of time. But these include collegiate recovery communities, recovery high schools, and these things vary a lot according to how structured they are. Some of them actually have lots of programming. Some of them have almost a clinical level support. Others are really just a drop-in center and an opportunity for abstinent programs. And similarly for recovery high schools tend to be relatively small, linked to existing high schools, and they're basically meant to provide alternative peer groups, because when adolescents return from treatment, it normally takes them about 4 to 6 hours before they are offered drugs. So clinical recovery management is a lot of the aspects of treatment following you into sort of an aftercare program. And so I'm going the wrong way, sorry. Recovery housing is, these different housing resources for people and who are developing and trying to maintain recovery. They vary a lot in how structured they are. The evidence is quite strong that these are very helpful. Basically staying in a recovery house is associated with less substance use 2 years later, lower incarceration rates, greater employment, higher income, less legal behavior, more likely to actually regain child custody. So I think, if society is going to invest, recovery housing is a phenomenal place to actually invest. This slide, which unfortunately because of time situation, I'm going to breeze through, shows the different levels of recovery residences. And this is a slide I got from information from PAR, the Pennsylvania Association of Recovery Residences. And they're very related to the national organization. So these are the same structures. And you can see from going from level 1 to level 4, what they're really adding is structure. Level 1 are really Oxford houses. They're democratically run. Level 2, you get basically a little bit more, you maybe get some drug screenings. You get maybe one person who's compensated. When you go to level 3, you get more training for the staff, a little more administrative oversight. You get life skills development courses, and you go to level 3, and then you get really something almost similar to extended care in terms of having clinical staff. So recovery organizations, community centers are basically drop-in centers where people can find the support that they need. They act very similar to collegiate recovery communities. They provide people a lot of support that they need, negotiating government systems. They are run by paid staff, so they're more expensive than 12-step 12 steps themselves, but they basically are 12-step community centers. And a lot of this stuff is done through peer-based support rather than having professionals. You actually have people who have lived experience themselves, and they can get training and then be certified as peer recovery specialists. And these are my conclusions. Went over a lot of stuff. I should probably stop talking. But basically, to sum up, I don't think that we're studying recovery in in the appropriate way. I think we need to study it in a much more dynamic fashion that actually captures the process, because if we're going to intervene in the process, we need to understand it on that micro level. And as a society, we really need to invest in recovery support programs if we're going to break the revolving door or remove the revolving door of treatment centers.